Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks so much, everyone. It is great to be back. I'm going to talk about a few highlights from the IAS conference that just finished yesterday. I will apologize in advance that there's no way that I could hope to cover the breadth and the depth of the conference in 15 or 20 minutes of slides. So I've picked a few key clinical trials that I think would be of greatest interest to the group here. And then I always like to put a lightning round of don't miss key takeaway points at the end of some others that we won't go into the data quite as much, but still pretty relevant. So here are my disclosures. So here's what I'm going to talk about today. 2 studies looking at long-acting antiretroviral therapy in clinical trials. 2 studies looking at different applications of Lenicappavir, one in treatment-experienced people with HIV and one in treatment-naive people with HIV. It's a pair of studies. I'm going to, similarly on the theme of long-acting antiretrovirals, look at a PK study of monthly oral islatravir as PrEP, which is a safety and PK study data that is exciting, and then look at 2 MDR-TB and 1 cryptococcal treatment study. So diving right in, starting with the Lenicappavir studies. So Lenicappavir is currently in clinical trials, first-in-class HIV capsid inhibitor as its mechanism of action. And there's good in vitro data that Lenicappavir is effective against HIV with multi-class resistance. So one potential application is using Lenicappavir for highly treatment-experienced patients with multi-drug class resistance. So this study looked at both oral and sub-Q depot long-acting Lenicappavir in highly treatment-experienced people with HIV, defined as people with resistance to at least 2 agents from 3 of the 4 major classes, and to have available less than 2 active agents on their optimized background regimen. So participants were brought into the study, were screened in a pre-randomization period before the study to see if they had detectable viremia above 400. If they did have detectable viremia, then they were randomized into the randomized component of the study, and then that was blinded. And then if folks were actually under 400 copies in the pre-randomization stage on recheck, then they would go into a non-randomized cohort, open label, observational with long-acting Lenicappavir, but they were not randomized for effect in the blinded fashion. So the effect results we'll be talking about are from the randomized arm, but safety data comes from all 3 arms. So in the run-in phase, the randomized cohort was randomized to either adding oral Lenicappavir alone to their existing failing regimen. The placebo group, 12 people, had a blinded placebo added to their existing failing regimen. And then they were transitioned into the maintenance phase after 14 days with a sub-Q depot Lenicappavir injection meant to cover 6 months of therapy, which they would receive twice over 52 weeks, and then on an optimized background regimen based on their resistance pattern. And then the placebo group was then transitioned to maintenance with oral Lenicappavir and then sub-Q Lenicappavir every 6 months for a year, again on an optimized background regimen. So longer run-in period with this group. So here are the week 26 results of this study. Bottom line is that for everyone in the randomized group, so the 2 groups that got sub-Q Lenicappavir, at 26 weeks, 89% of the population had HIV viral loads less than 200. And this was true even then moving over to this slide box here. This is looking at the number of active agents in the optimized background regimen. Even in people who had no fully active agents in their optimized background regimen. So they were getting functional monotherapy with the lenacapavir. There was still 67% of virologic suppression less than 50 at the 26 weeks. If people had one active background agent greater than or equal to 2, similarly high to having at least one background efficacy. But importantly, there was virologic data at 26 weeks on all participants. No participants had missing data. The resistance data that came out is somewhat interesting. So looking at this slide here, we see that, again, of the randomized cohort, the 36 participants who were randomized to blinded oral or sub-Q len run-in, 31% met criteria for resistance testing with detectable viremia. 7 or 20% had no emergent lenacapavir resistance, but there were 4 people who had emergent lenacapavir resistance. Everyone remained on lenacapavir, and 3 of the 4 subsequently suppressed without a change in lenacapavir. 1 of them did have a change in the background regimen. No participant at this point developed additional resistance to their background regimen agents. So some emerging resistance, but overall pretty minimal in an otherwise highly treatment experienced group. And then in terms of safety and tolerability, there were no SAEs recorded related to the drug, no adverse events that led to discontinuation of the drug, and other efficacy results that were looked at. There was a median CD4 increase of 81 over the 26 weeks, and none of the participants had a CD4 less than 50 at the week 26 cutoff. So overall, conclusion that it is effective at this early time point at 26 weeks, lenacapavir adding to an optimized background regimen for highly treatment experienced people with HIV, but with a caution that some resistance does emerge. Okay, flipping the study to look at same drug of interest, lenacapavir, but in this case, it is looking at a population of treatment-naive people with HIV. So the study had the same idea of having an induction phase and then a maintenance phase for treatment. We'll be looking at the secondary endpoint, which is the week 28 data here for this study, which is looking at viral suppression at the end of the induction phase of new antiretroviral therapy for treatment-naive individuals. So this study looked at 182 folks and randomized them 2 to 2 to 2 to 1 to these 4 different treatment groups. So one group was the control group, which received daily Biktarvy as the control, and then 3 treatment groups containing lenacapavir, 2 with sub-Q long-acting lenacapavir, the other with a daily oral lenacapavir. So everyone started, all of the 2 depot lenacapavir groups, we have their data up until week 28, which was the end of their background regimen. So everyone with the len had len in addition to Descovy that was taken daily. And then the plan is for at week 28, people would switch to a different single drug background depending on which of the 2 depot arms they were in. So a little bit of a complicated design, but to simplify for the discussion of what outcomes we're looking at here, it's really 2 broad comparison groups. There's any lenacapavir versus standard of care. And then within the lenacapavir groups, there's 2 groups that can be combined into thinking about them as a background injectable len for 6 months with daily oral Descovy compared to daily oral len with daily oral Descovy. All right, so the week 28 outcomes at the end of that induction phase, we see very high levels of virologic suppression across all groups. So the green group here, this is the control group, the Biktarvy group. These blue-purple bars are all the lenacapavir groups, and virtually everyone is suppressed under 50 copies, with 4 people over 50 copies, still very low, and then a few people that don't have HIV viral data for the time point. This inset graph here shows the viral curves of these regimens. So again, this top regimen, the green is the Biktarvy, and the other, all of the lenacapavir are pretty indistinguishable at hitting very high levels of viral suppression. So the pooled group of lenacapavir, either the sub-Q or the oral, all of them on average had a suppression rate of 94% at week 28. And so The study also looked for any emergent resistance and also did see some emergent resistance to lenacapavir that emerged. So one patient had resistance detected at week 10. This is a curve of the patient's viral load. This was their viremia at initiation, had an oral run-in period with the oral lenacapavir. Viral load dropped substantially, but then rose again. And at this point, sequencing detected lenacapavir mutations in the capsid and RT mutations. They did have some additional viral suppression after that point with no change. And then at the point that the viral load rose again, they were switched to a suppressive regimen with AZT, 3TC, tenofovir, and dolutegravir, at which point they fully suppressed. The authors note that lenacapavir in the plasma concentrations was at target levels throughout this entire period, so resistance did emerge even in the setting of therapeutic targets. So that remains kind of a warning note about the potential for this drug. But taken together, the two studies suggest good potential for lenacapavir, importantly with the option of having a long-acting sub-Q medication that may eliminate the need to take daily oral medication, potentially, or at least make it fewer daily pills possible. Moving from treatment to PrEP, I'm going to talk about a study that Sharon Hillier presented looking at islatravir, another novel compound that is an oral monthly new mechanism agent. It's a nucleoside reverse transcriptase translocation inhibitor. So it's being developed for PrEP and potentially for treatment in combination with lenacapavir, in fact. But this study looked at low risk for HIV, so HIV uninfected, low risk for acquisition adults who were randomized to 2 doses of islatravir as well as placebo and followed for safety and the pharmacokinetics of concentration. So this was not looking at efficacy. These were intentionally recruited low risks for HIV acquisition. So was not looking at how well islatravir performs at preventing HIV, but looking primarily at the safety and tolerability of monthly oral dosing at the 2 different doses. So in terms of safety, looking at the graph on the right, there were about 60% of participants had any adverse event at all, but the number of serious grade 3 and 4 adverse effects was very low in the single digits of participants who had them. And there were some grade 3 and 4 adverse events, but these were all transient and asymptomatic and included elevated creatinine, elevated lipase. There were a few rare, occurring in only 1 to 2 people, adverse events, AST increase, CK increase, neutropenia, also all asymptomatic. And overall, in terms of adverse events, 2 participants of the 242 were discontinued in the study due to AEs that were mild. One, I think, was itching and the other was a rash, but they were considered to be drug-related and overall quite well tolerated in the doses that were taken, both the 60 milligram dose and the 120 milligram dose. I think this graph on the right is probably the most interesting graph to come out of this abstract and raises some really interesting questions. So to orient you to the graph, the red dotted line is the predetermined therapeutic threshold of islatravir needed to prevent infection or control the viremia. And the dotted line is on the position for the 2 different doses given. So the top line is the 60 milligram dose. The bottom bar is the 120 milligram dose. And there are 3 time points measured looking at the pharmacokinetics. So 4 weeks after the first dose, so right at that point before they would have their second dose of islatravir is the first point, and everyone has concentrations of islatravir well above the therapeutic threshold at the end of that 1 month. Then 4 weeks after the last dose was measured again, so again, similarly high therapeutic concentrations well above the therapeutic threshold. And then after the end of the study at that 6th dose, 4 weeks after the 6th dose, there was another waiting period of a month and concentrations were measured again. And interestingly, in this group of participants who had concentrations both at the 60 milligram dose and the 120 milligram dose, 2 months after their last dose of treatment or of prevention PrEP, they still had everyone had a therapeutic concentration well above the therapeutic threshold. So raising some interesting questions of, could we, at minimum, potentially take advantage of this persistence of therapeutic levels to give us reassurance that monthly dosing is certainly the most frequent that we'd need it, or even push it out further to dosing every 2 months for PrEP, which would be an even lower burden. There are currently trials underway in women and adolescent girls in sub-Saharan Africa and in men who have sex with men and transgender women in the US, looking at monthly islatravir for PrEP. So we will have efficacy studies. So we will have more efficacy data later on. All right, now we're headed into the final lightning round. 3 really important studies looking at the important co-infections of TB and cryptococcal meningitis. So the first 2 studies I'm going to talk about are both looking at treatment regimens, oral treatment regimens for multi-drug resistant TB. The first study is the TB practical study that was presented by Dr. Mata. And this is a study looking at 3 different all-oral regimens compared to the standard of care regimen for multi-drug resistant TB. And it was an adaptive trial, so 3 experimental regimens were trialed against the standard of care, and then the best of those was selected to move on to a 1-to-1 comparison with standard of care for the rest of the trial. 25% of the study population also had HIV, and the regimen that was selected after the first phase to continue on to the second round of randomization was the bedaquiline, protomimid, linezolid, and moxifloxacin combination regimen. So the second round of randomization was 120 randomized to BPAL plus Moxi and 122 randomized to the local standard of care. At this point, the DSMB, at a scheduled midpoint evaluation, actually terminated randomization due to lack of equipoise. And at that point, the interim results with the primary outcome of treatment failure, treatment discontinuation, death, combined outcome of all of these negative outcomes, the results at that point strongly favored the all-oral BPAL moxifloxacin regimen. And this difference was driven largely by multiple discontinuations in the standard of care arm due to not tolerating the medications and 5 deaths, whereas there were no deaths in the BPAL Moxi arm. A study conducted somewhat in parallel looking at a very similar regimen is the Xenix study, which was also conducted, both of these studies were conducted in South Africa, Georgia, Moldova, and Ukraine, I believe, 3 Eastern European bloc countries and South Africa. The Xenix study was also looking at multi-drug or extensively drug-resistant TB, highly drug-resistant MDR-TB, and in their enrolled population, 20% also had HIV. And the Xenix study was comparing the regimen of bedaquiline, protomimid, and linezolid, but looking at the observations that many people being treated with that regimen in prior studies experienced toxicities from long-term 6 months of high-dose linezolid. This study, the Xenix, was looking at trialing different durations and different doses of linezolid along with bedaquiline and protomimid. So in Xenix, everyone got 6 months of bedaquiline and protomimid, and then they were randomized to 6 months of high-dose linezolid, or 2 months of high-dose linezolid, or 6 months of low-dose linezolid, or 2 months of low-dose linezolid. And the bottom line is similar efficacy across all of the randomization groups. The outcome of 6 months post-treatment cure was 84% to 93%, which were quite similar across the different linezolid dose groups. And unsurprisingly, in the either lower dose, 600 linezolid groups, or the shorter course of linezolid, 2 months instead of 6 months, there were many fewer side effects and toxicities seen. So this gives strong evidence that we may be moving towards the possibility of a lower toxicity, short course, all oral treatment for MDR, XDR-TB, including in people living with HIV. Last but absolutely not least, I want to highlight the results of the Ambition study, which is presented by David Lawrence. And this is a study looking at 2 treatment approaches for cryptococcal meningitis in people with HIV, almost all of whom had a CD4 well under 50. So the study was comparing two different induction phases for cryptococcal meningitis, and everyone got a consolidation phase of fluconazole. So the two arms were the intervention arm, which was a single dose, high dose of liposomal amphotericin B, plus 14 days of 5-FU and fluconazole, and comparing that to standard of care, WHO standard of care, which is 1 week of IV amphotericin B plus 5-FU, followed by 1 week of fluconazole. So everyone got 14 days of induction therapy. The difference is how much amphotericin and in what format. And very importantly, this study showed that the single dose, high dose ambisome arm was non-inferior to the standard of care induction arm. It was very far away from the non-inferiority margin. It was firmly non-inferior. And there were substantially better safety profiles and toxicity profiles in the ambisome group, given the known toxicities of amphotericin B. So strong call to review the WHO guidelines and increase access to 5-FU as a necessary component of both of these regimens, but I expect that this is going to result in a WHO guideline change very soon. All right, that's my whirlwind tour of HIV treatments and co-infection treatments as seen in this week's IAS. Happy to take any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.